The next session is a very interesting panel discussion moderated by none other than our own Dr. Alka Kriplani Madam and Dr. Isha Kriplani. The slide, please. Madam, though requires no introduction, Madam, still in brief, Madam was President Foxy, President GSA, President Delhi Gynec Obstetric and Gynec Society, President AOGD, Editor for Asian Journal of Obstetrics and Gynecology Practice. Madam was on editorial board for 9 journals, co-chair for FIGO. Madam is awardee for Padma Shri, BC Roy National Award, honorary FRCOG, and multiple publications and lot of scientific workshops to Madam's credit. I will invite Madam to for this interesting session. And we have dynamic young gynec endoscopic surgeon, Dr. Isha Kriplani, from the Department of Obstetric and Gynecology, Paras Hospital, to co-chair the session with Madam as a co-moderator. Madam, most welcome.
You have to do panel on complications of laparoscopic hysterectomy, prevention, detection, and management. So I'm not going to show you rare things. I think we will discuss common day-to-day issues which come up during the course of hysterectomy. So can I ask Isha, please start the slides.
Good evening, esteemed panelists and audience.
So the first case is very common issue is urinary tract injuries, and I'm not going to go into this big list. I'll just discuss with you all few cases in real life which we have witnessed. There is lot of disturbance. So this is a patient. Isha, would you like to present?
Certainly. A 44-year-old para 2 life 2 with endometrial hyperplasia with history of previous 2 cesarean sections. The procedure being done is a TLH, and as we can see, the bladder is densely adherent.
So this is the patient where TLH is in progress, and I stand at Madam, we can see a catheter seen through the bladder. So I would like to ask, anybody can respond, how do you diagnose a bladder injury during cesarean section?
During cesarean?
Sorry, during hysterectomy, sorry.
Ma'am, firstly, so many times it is found that you can see a Foley's catheter, that is one. Secondly, leakage of urine into the peritoneal cavity. Thirdly, you can have a urosac bag full of gas, that is another entity we can diagnose. And 4 times, inadvertently, you can find spurter coming up if there is a concomitant ureteric injury, ma'am.
I think this is a perfect answer. And I would like to again emphasize, as the panelist has said, you see suddenly your assistant will tell the uri bag is getting inflated with the gas. And that is a very, very important marker for bladder injury. So can anybody tell me what is being wrongly done in this case? You can see the bladder, a hole is being made in the bladder.
Madam, one more thing. What happens is that in certain hospitals and certain places, sometimes the staff forgets to close the urine bag. So there will be no gas in the bag, but the pneumoperitoneum starts going down. You see the distension starts going down because the air leaks through the bladder and it goes out through the urosac bag.
Yes.
So the distension also starts going down. So if the urinary bag is open, then there is no gas in the bag, but then this kind of thing can happen.
Very good. So can anybody respond that what was why this bladder got opened?
One is,
you can see there was no hole, and then the hole is being made where the surgeon went wrong.
So
actually, when we are dissecting, the plane should be clear and avascular, or clear bloodless field has to be there. We can push the bladder over the cervix, but here there is no cervical tissue, but the tissue which is there is the bladder, and the forceps was put and opened at that place only, and which has opened the bladder.
One is
Another thing,
Can you
madam.
identify, please, before speaking, so that everybody enjoys who is speaking?
Madam, this is Dr. Masrani.
Yes, Dr. Masrani. What is
Yes.
wrong you think is being
Madam,
done by the surgeon?
Madam, since the patient is previous to LSCS, I think we would have been better off making a lateral window and
Very good. Excellent.
that is in the front of the
lateral
uterus.
window would have been a better idea. But
Yes.
what is wrong? There is obviously, when I reached there, I said, oh, there is something very wrongly done here. Again, watch the video. When they are dissecting the bladder, see?
Dr. Vaman, madam.
Yes, Dr. Vaman.
Actually, bladder has to be pushed on the cervix, and here the forceps is put and opened. Actually,
Very good.
forceps has to be closed, and we have to push the bladder down over the cervix. This action is not done here. Instead of that, forceps is put there and opened, and that's why the rent has created.
So this video is to show when you make a very junior person sitting down and he doesn't know how to show with a manipulator. See the manipulator and the surgeon is not dissecting in between cervix and the bladder. He is just dissecting the bladder wall,
Bladder
and that is how a hole has occurred. So as somebody very nicely answered that you will look for, here Foley's catheter is just
couple
shining.
of can I speak, madam, for a minute?
Yes, sure.
A couple of things I would like to add. One is the lateral window technique involves exposing the uterine vessels on the sides and going parallel and anterior to the uterine vessel, where so the principle is bladder is adherent at the scar, below the bladder is free, below the scar. So you create a tunnel below the bladder, between the cervix and the bladder, tense up the bladder and dissect it across. And the second is, of course, like you said, manipulation. The third thing is the uterus should be pushed to the opposite side from where you are dissecting the bladder, from which lateral side.
That's also a very, very important point.
Madam, can I add something to this? If
You
given a
just
position?
identify yourself because
This is Hemant here, madam. Hemant.
yes, Dr. Hemant.
Yeah, okay. So what we do is, in case of previous LSCS, irrespective of the number of LSCS, first of all, we try to open the round ligament a bit laterally. We are not very close to the uterus. So we enter into the right spaces or the normal spaces, as you say. And for any central adhesion, it is always better, be it rectum or bladder, we have a principle of going from the normal area to the abnormal area. Now, what Nagendra mentioned is a very important point. Sometimes you might not find the lateral window, even if you have skeletonized the uterine vessels properly. Even the ascending uterine, just go one level above the uterine vessels and you will definitely find the intrafacial plane over there from the lateral side. Another thing, what we do is we expose the posterior cervix, because that is the virgin area, the posterior part of the cervix, which gives us an orientation about where the anterior part of the cervix would be. So these are few principles which we follow and we normally get it right. So the thing is, first to identify the differentiation plane between the dome of the bladder and the cervix as much as possible. Once you get that from the normal area, then you will almost never open the bladder.
Dr. Vaman here, madam.
Anything else?
Yeah, Dr. Vaman here. One basic thing, whichever technique you apply, lateral window, or you can open the peritoneum, or you come from the broad ligament. One thing is very clear, that unless and until the bladder fillers you dissect and push down, don't push the bladder. Otherwise it will get open. So the adhesions and bladder filler has to be cleared on the cervix, and you should have a clear-cut cervical tissue, and then only you push.
So we have got very good practice points, how to identify the injury and how exactly to go in the dissection. And the next is how to prevent this ugly complication. I think it is also partly answered. To prevent it, lateral window approach is very important. Going behind is very important. And don't take head on the bladder. Here what is being done. So if you are dissecting in the wrong plane and in the musculature of the bladder, definitely you will open the mucosa. Now the next question is, once you have seen this injury, whether to continue with the procedure of TLH first or repair the bladder injury first. Anybody can respond.
Continue with the TLH first, madam. It's important that.
Any reason behind that?
Yes, madam, because what is going to happen that you're going to close the rent and then you're going to further handle the uterus, remove the uterus from vagina, etc., etc., and that is going to make your stitches loose. So best thing is to finish off the hysterectomy, then tackle the bladder because there is a less tension on the bladder mucosa.
So
Bladder wall.
first you finish off the procedure.
Yes.
Mark
The only
the
thing.
opening, and then at the end of the procedure, nicely dissect it away and you suture. That is the best way, I agree.
Yes.
So
Another thing.
anybody who differs with doctor?
One more thing, madam. One more rider with this. That when you, for example, if you see that the hole is too small,
Yes.
the hole that you have made is too small, then you can just tag it with a small stitch independently so that it is not lost and you can identify it later. Otherwise, sometimes what happens if the bladder wall falls on the hole in the bladder, sometimes it becomes difficult to identify where you had opened the bladder.
Yes. So very small hole.
So you can just
Shall I add, Dr. Vaman here? Yeah. The thing is, when we open the bladder, the situations are bladder adhesions, previous surgeries. So when there is a single opening, don't be in a hurry to close that because we may open the another rent also if while dissecting.
Yes.
One thing, and another thing is you have to take the advantage of that hole which we open the bladder. You can hold the posterior flap of the bladder and you can dissect further if the difficulties are occurring more. So instead of closing the rent, you can take the advantages of that rent for dissecting the bladder.
Very good point. So what you want to say, once you have opened the bladder at one place, make it as a marker and you can nicely dissect the bladder because one place it is open. So you will be easily identifying the margins and prevent further holding in the bladder.
The procedure becomes faster, I guess, madam, then once you have opened the bladder because you know everything
True.
Only disadvantage is sometimes the leaking of the urine may be there, so you have to instruct and do intermittent suction in this.
So that is automatic, washing.
But ideally, not much of the leaking per se.
Yes.
Yeah.
Sometimes, Isha, can you just summarize these points? Preventing bladder injury.
Also, madam, one more point that if you think you have opened the bladder at one point, at one place, be sure to check that you have not opened bladder at two other places also.
This is a very important point.
Because we think ek hi khula hai, we close that, but then we have not done a justification to that, and then the problem happens.
Yes. I would
Dr.
like to
Kalyani,
ask
ma'am.
Isha just to summarize. Let us proceed now because in one case we cannot be stuck. And there were wonderful answers from all the experienced panelists. Isha, can you just summarize?
Certainly. So to prevent bladder injuries, we should have a clear understanding of the anatomy. We can delineate the margins of the bladder with the carbon dioxide or saline. We can use the lateral window approach for dissection in the case of an adherent bladder. And we should dissect the bladder adequately, at least 3 centimeters beyond the point of vaginal.
So now the next issue is injury has occurred. Next. So next. No, this is just for checking. Do you people do post-operative cystoscopy after TLH? How many of you are doing and how many of you are not in favor? Then we will tell what is the evidence.
I don't do it, madam. Hemant here. No routine cystoscopy.
And Nagendra here, no cystoscopy. No cystoscopy.
Even for difficult frozen pelvis, no.
See, whenever you go in the West and
Madam,
any colleagues, OT, you see they always do it. Cystoscopy at the end.
You can inject methylene blue, madam. You can inject methylene blue and check for any thinned out areas or any rents.
नागेंद्र वो थर्मल इंजरी पता नहीं चलता है मिथिलेन.
No, none. Please don't talk with each other. Let us see. Otherwise, people will not enjoy it. So,
Dr. Vaman here. Actually,
we were discussing the question: what is the value of post-operative cystoscopy after TLH? When in many countries, people do routine. So let us see, Isha, what is the evidence?
So most of the studies suggest that it is controversial to do it prophylactically in all surgeries, but where integrity of the bladder is questionable, cystoscopy should be done at the end.
So in difficult cases where integrity is questionable, and as somebody pointed out, we always do saline irrigation or methylene blue, and if the bladder gets filled, we are reassured that there is no rent in the bladder.
So, madam,
Cystoscopy has one added advantage that you can see both ureteric jet of urine from both the ureters. Anybody wants to add anything?
Yes, madam. Yes, madam. I would like to add, Makarand Masrani here.
Yes.
That see, if you are a beginner, if it's a young gynecologist who has started doing laparoscopic hysterectomy, he should do cystoscopy regularly after each hysterectomy. The reason being that, number one, he gets used to what is cystoscopy. Number two, now if you have a thermal injury or if you have taken a stitch through the bladder while closing the vagina, there won't be any leak, or if you inject methylene blue, you won't be able to see it properly. But if you do a cystoscopy, a thermal injury can be nicely seen into a white area in the bladder, so that okay, you've gone through and through.
Good.
To later
So
on
now
leak.
I would like to ask other panelists, do they agree with Dr. Massan or anybody disagree? Because
Madam Hemant, can I?
Vaman here, madam.
Yes.
Actually, instead of making a dictum that we should do or we should not do, actually, if we are...
No. I asked you whether you agree with the doctor who made the statement that all youngsters
true.
do it in routine.
I agree with him. Yeah, I agree with him.
You agree with him?
Yeah,
Anybody
I
who
don't.
disagree?
I don't.
No, madam, can I put in my word?
Sure. Just
yeah.
identify yourself.
Yeah, Hemant here, madam.
Hemant.
In case of suspicious, definitely go ahead and
No,
do it routinely.
I'm just asking
routinely,
you the statement made by doctor that he says all youngsters in all TLS they should do cystoscopy. You agree
Not for
or
all.
you disagree?
No, not at all.
No.
Not totally
for all.
agree. Not totally agree.
Dr. Kalyan here, ma'am, not for all cases, ma'am.
Very good, Kalyan. So what are your reasons? Give a clear statement.
Ma'am, wherever indicated, there only you should put a cystoscope. Where you are not suspecting any injury, methylene blue dye test is negative. There is no indication of doing a cystoscopy routine TLH, ma'am.
No,
Blanching
what-
is a very vague appearance. Blanching has no meaning. This is Dr. Nagendra. It
Blanching
may or may not suggest. You see blanching quite a few times. I have some videos. You see blanching,
I
but it doesn't
think
seem to be
the
having any relevance.
evidence is
And
clear.
we are not going to treat the
And
blanching.
not having blanching does not mean she will
One
not
by
develop a
one.
fistula.
I think that there is evidence that it is not recommended in all routine patients, but whenever there is doubt, one can go ahead and, as Dr. Hemant said, that youngsters should, yes, they should be, all gynecologists should be, knowing to do how to do a cystoscopy, but I partly disagree that all patients should be cystoscope because every procedure has its own,
Madam,
issues.
can I add one more last point, madam?
Yes.
I'm not interrupting you. If you want to complete something, you can complete, madam.
No.
please.
You are most welcome.
About the ureteric jet also, I'm not convinced that cystoscopy should be done just to see the ureteric jet or the jet of urine. I believe if you're in doubt, always expose the ureter and see the peristalsis and the course properly rather than relying just on your, cystoscopy view of urine pulsating out in at least difficult
Idea behind
cases.
is if ureter is transected completely, you will not see the jet. If there is thermal injury to ureter, it will not carry any meaning whether ureter jet is coming or not.
So better to dissect the ureter and expose it rather than rely on these things. That's what I'm trying
Youngsters
to say.
should know that. So that is
For youngsters, fine. I'm just talking about routinely for others also.
Yes. So we will proceed further. Now, how to manage when a bladder injury occurs? There are two issues I want my esteemed panelists to clarify. Whether you people, what are you doing? Whether you are suturing in 1 or 2 layers, and what is the suture material you are using? So one by one, you can tell me.
This is Nagendra. So although urosurgeons do it in single layer, if I am repairing my own injury, I would prefer to do it in 2 layers. I use number 2030 Vicryl.
Very good. Next person.
First layer is continuous layer, second layer is figure of eight.
I
You
would-
can take in continuous, whatever. doesn't
Excellent.
matter.
I would like to know from other panelists if they have any different way, then they should come.
Recently, we have tried barb also, barb sutures, and it also works very well. Even in bladder, and urologists have also started using it without any this thing. But yes, single layer is sufficient. But in case of doubt, always recover it with the second.
Any panelist would like to add something to this?
Yes, madam. Dr. Masrani. Dr. Masrani here. What I would like to add is that use the 30 Vicryl to close the bladder in 2 layers, but use the smaller needle. Don't use the standard 40 mm needle. Use the smaller needle, 28 or 30 mm needle, so that the needle can rotate properly. So the smaller needle life becomes easier.
Anybody would like to add any other practice point?
Madam Nagendra here, one small point I would like to add. One is I have to ensure that the bladder is dissected adequately from the vagina. That is one thing. And the second thing, I personally put a omental graft, omental patch there.
Very
I
good.
bring down the
Anybody would
patch.
like to add anything?
Hemant here, madam. Normally the injury is at the level of the tribal suturing, so that you don't include the ureteric opening. And surprisingly, as Nagendra also mentioned, that urologists prefer to close it in single layer. Many of urologists say that. But I think 2 layers is good enough.
You people have given very, very good practice pearls. I would like somebody to respond. In olden books, it is written that exclude the mucosa. What is my esteemed panelist's opinion?
We used to take the mucosa.
Ideally, you should. Even urologists say you should try and exclude, but most of us don't, frankly.
Madam, it is easy to write in the book to do it practically.
But do it practically.
It is not.
And you don't feel confident, and it's not, sufficient enough. If you exclude mucosa, you cannot take those lovely bites.
Yeah, madam.
Yeah, true.
First layer should always be through and through, I think, madam.
Actually, when we take the mucosal layer continuous pattern, we'll have a good suture line and good satisfaction. Then and then only we take second layer as an interrupted suture.
How you people are ensuring that your repair is adequate?
Again, there is controversy, because now urologists recommend there is no need to test.
No, I am not going into controversies. I just want you
I
are
put methylene blue.
senior endoscopic
Ma'am,
surgeon.
Dr. Kalyan here, ma'am.
I want to know everybody's individual.
I put methylene blue and check it.
I'm Dr. Kalyan here, ma'am.
How you are
I
ensuring.
like to put methylene blue and check once again whether it is intact, because sometimes some other additional injuries can be seen if you are going to put methylene blue.
So you
I
are
do
doing it
2-layer
at the end of
closure.
first layer or both the layers?
Both
the layers.
layers, ma'am.
Yeah.
Very
And,
good.
and
Dr.
secondly,
Vaman
after testing, if everything is fine, I still take 2 layers, whatever urologist advise.
Okay.
Yeah.
Okay.
Vaman here, madam. The thing
Yes,
is,
Vaman.
when we are taking the mucosal layer, take one bite behind the that opening rent. Behind the rent you go first.
Yes.
And
Edge.
at the end also, you go behind the edge, one thing, continuous layer, and then second layer, interrupted layer. Don't do methylene blue, because when we suture it immediately, it can leak. Don't do anything. It will heal. We have to give time for the tissue to heal.
Madam, Dr. Masrani here, I totally agree with Dr. Vaman Gorke, because what happens that when we close the bladder, we are very happy, we have done a very good job. So, assistant to put methylene blue and fluid from below, and then we over-distend the bladder.
True. That is
Over-distend, again the stitches which you have taken in a fragile mucosa, they cut through and leaking starts. If
So
it leaking
a very
starts, there is
important
no stitching.
issue you have highlighted, don't over distend the bladder too much. 100 to 150 is good enough to check for integrity of the
Madam,
bladder.
30, 40 ml.
And
Madam, 40 ml.
thankfully, majority of TLH injuries are at the fundus of the bladder. But you have to be careful, because if you are dissecting deep down, nearer the injury to trigone, then you have to be very careful that ureteral kinking, inadvertent suturing doesn't come in your way. And suppose, Dr. Masan, you have done cystoscopy or you can see that it is injuries near the trigone. Can you take any extra precaution? What are you doing in your practice?
Madam, I have not seen any injury so close to trigone. So, but if it is close,
Anybody has seen that person? Will tell
Madam,
me.
can I give a point over here? Recently,
sure.
I did an endometriotic nodule at the uretrovesical junction, completely involving the trigone and the opening of the ureter.
Very
So
good.
we
So tell me, how did you prevent ureter?
Madam, we didn't prevent anything. We completely excised everything, including the intramural portion of the ureter. We sutured that portion of the cystotomy, created a neocystotomy anterolateral, and re-implanted the fresh part of the ureter over there. And it's been tell me, madam.
This is an extreme situation, but if you have done an injury near to trigone, then in that case you can catheterize the ureters and
you
then
can stent
suture
it.
it. That is a very simple
Very safe.
and very
No,
good practice point.
what I meant to say is that even if you have to do something radical like this, it's okay.
For that, Hemant, most youngsters will not be doing that. You will have to come in and you can do anything then. But in a routine, when you open the bladder and it is near the trigone, it is a good idea to catheterize ureters.
Madam,
to prevent
Madam, Dr. Masrani here.
Yes.
See, question is whether you are near the trigone or you are near the ureteric opening. Trigone is a triangular area.
That I agree. I mean 1 to 2 centimeter near ureter.
Yes, then it is okay. Then you catheterize the ureter, not because you are going to take the ureter in the stitch, but we want to prevent the kinking of the ureter.
Kinking
When
is
you take
very,
the-
very important.
Kinking is
So,
very important.
I think you people have given such excellent answers. I don't think we need to recapitulate. But recently, and for many years, I am suturing my fistulas or these injuries with barb suture only. And there is enough evidence now. Barb suture is a good alternate, and it is so much patient friendly. And anybody will tell me if the injury is very small or if it is big. Is there any change in your approach? Suppose it is a very small hole, or
Can
on
I
the
add,
other
madam?
hand, it is a big hole. Is
Hemant,
your
madam.
treatment different?
Yes.
Hemant, madam, any hole should be sutured. I mean, if you see a hole, I suture it. I don't leave it.
I agree with you.
The only difference is if it's a large hole,
Uh-huh.
Nagendra here, that if it's a large hole, is it close to the ureteric orifice? That is the only thing that might change your management slightly about stenting. Otherwise, the principles remain the same.
Very good.
I'll add one point, madam.
Let's recapitulate this evidence.
Madam Hemant here,
Yes,
one last point. In between, a few years back, we punctured the bladder with the needle holder. It was a traumatic needle holder.
Uh-huh.
And we sutured that small rent also, because I mean, in heart of heart, you cannot leave any rent open, you know.
I 100% agree. All the literature, all urologists, they say very small defect. Isha, just read this evidence.
So a small defect less than 1 centimeter may be treated with Foley's catheter drainage. Cystotomies between 1 to 2 centimeter can be repaired with a single layer of delayed absorbable suture. And cystotomies more than 2 centimeters certainly require repair with single layer or 2-layer repair.
So what we want to emphasize here, any hole, whatever small it may be, what is wrong in giving sutures 2 or 3 so that you have a good night's sleep? Are esteemed panelists agreeing with me?
Yes, madam. Good night sleep is the most important thing in life.
And now everybody knows suturing, so what is the problem? So, yes. Now the next question is, and I don't want any bookish answer, how many days you people are keeping catheter and draining the urine?
7 days. Sujal, Dr. Sujal Muchi, 7 days now. We used to keep it for 11 to 21 days. Now, of late, we have reduced it to 7 days.
Anybody who differs with Sujal?
Ma'am, 7 to 10 days, ma'am.
Anybody?
A
Who
big
differs?
cystotomy, I think for routine cystotomy, 7 days is good
7
enough.
days, yeah.
7 days.
See, it depends on how complex is the injury. If it is very big, if it is very low, then individualize.
Longer.
By and large, now we have learned, when I was a resident, we used to keep for 3 weeks religiously. But we have realized if there is no cicatrization, no fibrosis, a simple injury which is sutured without tension, 7 to 10 days are good enough. Otherwise, in complex injuries, you may need to keep it for longer period of time.
Yes, ma'am.
Do you believe in before removing catheter, how many of you are doing cystography?
Never.
Anybody can
Never.
Never done.
Never.
This is very, interesting. All urologists, I don't know how many times you are calling and working with your urologist. I have seen at institute, all urologists will always do a cystography. And when I discussed with them, why are you taking her to radiology and doing, they said, what is wrong if I just put some dye and see if there is a leakage, I will leave the catheter for longer. Anybody who would like to differ with this statement?
Sometimes, madam, when they repair very large defect, it is not required in cases like ours, but in urology, when they remove a large portion of the bladder, sometimes, madam, they also want to see the capacity of the bladder afterwards.
Very good. Who is this person? Can you identify?
Sujal Munshi.
Sujal, very good. Yes. So that is the reason urologists get complex and we have simple, straightforward injury. But you should keep in mind if there is any doubt. So in ELH, bladder injury is very common. We made the injury. We discuss how to prevent. We discuss how to treat. We discuss post-op management. And now here is another patient. Dr. Isha, would you like to tell us about her?
A 48-year-old para 3 live 3 with a history of previous infections and multiple fibroid uterus underwent TLH. Intraoperatively, a bladder rent occurred. It was repaired intraop and patient was okay in the postoperative period. On post-op day 2, she complained of pain lower abdomen and abdominal distension. Leaking of clear fluid was seen from the ward.
So this is a true case which happened, which was referred to me, that TLH was done a day before. Bladder injury was detected, they repaired, and second day patient has distension and clear leak from the wall. Can any worthy panelist tell me what might have gone wrong?
Ma'am, Dr. Kalyan here. There is a likely chance that there is concomitant ureteric injury which must have been not diagnosed on the table on the day of surgery. Or secondly, there is another leak from the bladder where you are sutured, ma'am.
So, very good. Either there is unidentified bladder injury. One minute. Either there is unidentified another bladder injury or there is concomitant ureter injury. Now, I will ask by name because otherwise so many people are responding. Dr. Kalyan, now you only know how you will proceed with the management. How will you confirm whether it is ureteric or it is still bladder?
Ma'am, now I try to counsel this patient regarding that there can be another chance of some other injury. So I like to do a cystoscopy for this patient. I'll involve urologist for this case because he's going to know whether the catheter is going in the both ureters, and depending on that, he might diagnose a ureteric injury. That is one.
So,
Secondly,
do you people agree with Kalyan that you will talk to patient and take her to OT straight, telling her that we will do cystoscopy, or you people will do any other investigation?
I like to do
imaging.
IVP for this patient first to diagnose.
Please, who is responding? Identify.
I am Dr. Kalyan only, ma'am. So I like to do IVP for this patient.
But you said you are going to take her to theater and do cystoscopy. Then
No.
where you will do IVP in the theater?
No. First, I would like to do IVP, then counsel the patient.
Okay. No. First you will counsel. You can't do IVP without talking to her. She has come to your emergency and her relatives are very much in distress and she is leaking and they are making so much of ho-halla. So first you are counseling. Now tell me next what you are going to do. Which investigation you are going to do?
First,
Madam Nagendra here. CT IVP.
CT urography, madam.
That
CT
is
urography.
called as CT urography. Nowadays,
urography.
it has replaced these things. CT urography very nicely tells you all injuries, their size, how much is the leak, what is the condition of tissue. So CT urography, please, all youngsters who are listening to us, is a very good investigation to rule out a situation where patient comes like this, whether it is ureter, whether it is bladder. Okay, so you did CT urography and there is a hole in the bladder. Both the ureters are intact. Kalyan, since you offered, now you did CT urography and it is showing a hole in the bladder. How will you proceed now?
Now here also comes the role of counseling. We need to tell the patient that there might be any inadvertent another injury to the bladder which might have missed, or there can be a rent in the similar injury which was being corrected. So now
the patient says, now you are the God, Dr. Kalyan, I have heard your name so much. Whatever you think is right, do for me. What will you do?
So now this patient has come with a distension. First, I like to give conservative management for this patient for at least 48 hours. Once a distension.
So you have done CT urography and you will put her on conservative management. There is a hole in the bladder which is leaking in the abdomen and the fluid urea is 200. So you, okay. Are all Verde panelists agreeing with Kalyan or anybody differs?
No, ma'am. No, see, if you're...
Please identify yourself.
Yes, I am Dr. Masrani.
Yes. What will you do? You agree you will do CT urography?
Yes, absolutely.
Now what you will do, it is in your emergency.
Okay, if it is the day 2, I'll counsel the patient, get a urologist in the OT and put in a scope again and repair that rent.
So Kalyan, now you fight with Makran that he is differing and he says he is not going to wait for 48 hours. He is going to straight take the patient in OT. Let us make people who are with Kalyan and people who are with Masran. Please respond, Hemant Kanoji. I can see you smiling. Your voice is gone. You are not audible.
I am audible now. Am I audible now?
Now you are audible.
Yeah. We will do an immediate management as recommended.
No. Are you with Kalyan or are you with
Makran? Masrani sir.
Makran. Anybody else, Satyen?
I'll be with Masrani sir.
Anybody else? So Kalyan, you are singled out.
Okay, ma'am.
No problem. Loyals are always single, so no problem. But this is a real-time case. She came in our casualty referred by a younger colleague, and I'll tell you, we did CT urography and took her in the night time only in the theater, as all other colleagues are telling. Now, taking in the theater, what is in your mind and what is your plan of action? Dr. Hemant.
Madam, first we'll do a cystoscopy and see, where the rent is, what is the size of the rent, and then accordingly take a urologist opinion also.
So I will tell you in real life what happened. Her cystoscopy was done and we were not able to, inflate because all the fluid was going into the abdomen. So it was
that means the rent was very big, I guess, then, madam. The rent was very big, I guess. Yeah.
You know what had happened? There were 2 rents from the person. One rent he could suture and it was through and through cut anterior and posterior dome of bladder. So anterior they sutured, posterior they could not. And as we were discussing, always distend, always check, they did not listen to our panel. Maybe they were not in future. So the rent, one big rent, and it happens. You give a transverse incision, it went through and through from anterior to posterior wall. Anterior wall, they nicely sutured. Posterior wall was still open. So you do cystoscopy, you see a big rent, and you fail to distend the bladder. What is the next step, Dr. Hemant? What will you do? Doctor, I think we have lost contact with him. Kalyan, now you will have to take it since you were conservative, but now everybody has told you not to. So what will you do in the theater?
Now I like to involve urologists because it can be a medico-legal problem in the future.
Very good. Involve urologist. Urologist is, as you know, they don't know many times suturing and he comes and he's standing by your side.
once we have put the scope, I like to suture the bladder from where rent is seen. Secondly, now I am really going to be sure about doing a methylene blue dye test this time so that I don't want any more complications. I like to suture this in 2 layers, check the methylene blue dye testing, and then once you are sure, I like to also, maybe it's a controversial, put a drain here this time, ma'am.
It is not controversial at all.
Urologist says so, ma'am.
So,
Madam Makran Masrani here.
Yes, Makran.
See, first I would straight away put a laparoscope for the patient. Now,
So you will not do cystoscopy, no?
Madam, cystoscopy really, what am I going to find out? I already know there is a rent. So putting a cystoscope.
No. Tell this thing to Hemant.
No, the only.
Because he is going to do cystoscopy, no?
No, with the cystoscopy, the only thing is that I can find out how close the rent is to the ureteric opening.
No, because we were not able to distend, we could not make out anything. The scope was going in the abdomen.
Yes. So my this thing is that I'll put in a laparoscope. I'll follow as what you are saying, that we will see. Now what you say that the surgeon has gone through the anterior wall and the posterior wall. Okay. So now we have to see what is the distance between both the incisions.
Very good. It was, say, at the fundus, so 3 centimeter at the dome.
No, at the dome, but how much distance is there between the 2 rents?
3-4 centimeters.
Because if the rent distance is too small, then rather than creating 2 suture lines, one anterior, again I am creating one posterior, I would remove that much part of the fundus.
Oh, Dr. Vasan says that he will excise the bladder wall which is falling in between anterior and posterior, and he will make it one rent.
No, the reason I tell you why I am saying. Number 1, the problem is of vascularity, madam. Okay, because you already sutured anteriorly, you have made 2 holes. Again, if I am going to suture posteriorly, there might be a problem of vascularity. So rather make a proper nice hole and just suture it for once and for all. Otherwise, what will happen? When you take the posterior stitches, the anterior stitches will cut through.
So are you people
Madam,
with
can I make a
Dr.
point?
Vasan? Who differs from Masan?
Hemant here, madam. Hemant here.
Yes, Hemant.
I just lost the net in between, so I missed a bit of the discussion. But I think in this case, I will definitely involve a urologist.
Oh, these people brought a urologist before when you were not.
Okay. I'm sorry. To take their opinion, because I think in these cases, it is better to take their opinion and then proceed. Maybe we can operate, but let them
sometimes we have to guide urologist. You will agree with me. So what should have been done?
Management.
Common here, madam.
Not in this scenario, madam. I would definitely listen to the urologist.
When we involve the urologist, the things differ. And here, when we put the laparoscope, we can find the rent nicely, we can suture it nicely, and post-operatively we can put the drain, and we can put methylene blue because we don't want to take chance by suturing the third time bladder.
So the lesson from this case is that rent may be more than one. So please be very careful and check nicely at the end. Otherwise, she will come next or next day. And this is very nice. Kalyan is not wrong. It is old teaching that you should, wait with the injury, let the tissue reaction. But these are old things. Now the current literature and whatever. See, with a fistula, life is hell. So there is some evidence and good evidence that you need not wait for long time, and you can take the patient to OT as Dr. Hemant did and suture it at the same time.
Madam, can I make one small comment?
Yes.
In complex cases, involve a urologist and listen to them, because whatever said and done, they have 3 years of training and immense focus on that
nobody is
concept.
denying. You were not there. We brought a urologist.
Okay.
Yeah.
This is just as a take-home message, madam.
Yes. Now this is another case, and this is a real. The case is managed or seen by us. So, Isha, would you like to present this case?
41-year-old para-1 live one who's had a previous cesarean and grade 4 endometriosis with the fibroid uterus and history of 4 previous operations of endometriosis, 3 laparoscopies and 1 laparotomy. She underwent a TLH. Intraoperatively, there were dense adhesions. Immediate post-op period was uneventful. On post-op day 12, she came to the emergency with a sudden gush of clear fluid from the vagina.
So the patient came, she had multiple surgeries. When the surgery was started, dense adhesions all over, lot of, vascularity compromise. But patient went home very happy, third day after TLH, saying all thank you to the whole team. And suddenly 12 days after, she has sudden gush of fluid from vagina. Can anybody respond what might have happened?
Madam, can I respond? Dr. Nagendra here.
Nagendra, very right.
Yeah. So basically, it's obviously a urinary injury. Whether now we have to rule out now, since it's a previous cesarean endometriosis, it can be a ureteric injury, it can be a bladder injury, or it can be both. So the next step
can be anything. What your experience says when patient
ureteric,
comes
most likely
in the
ureteric.
second week with
second week.
without any problem, without
Most
any fever, what you have seen the patient has had.
Most likely a ureteric injury.
Excellent.
Here, it might be mostly ureteric injury, which might be because of avascularization of that particular portion.
Yes.
So, anybody else would like to add any other point?
Madam, I don't think so. These patients remain asymptomatic. They do have some form of groin pain. They probably neglected and they later.
Not necessarily, doctor. I have seen because in a big teaching institution, youngsters do, and the patient goes home nicely. I agree with you. There may be loin pain when there is obstruction to the ureter and hydronephrosis. But what happens? Many times they just come. And which ureter goes in TLH more commonly? Anybody would like to tell me?
The right side?
Right side is more.
Or ipsilateral surgeon.
Depends on which side you're operating from.
Yeah.
90% of time it
the
is
contralateral.
The right
Yeah.
for a person who stands on the left.
Yeah, so it's the opposite side more common.
And can somebody tell my esteemed panelists what exactly goes wrong so that the patient presents in second week? What goes wrong?
Ureter is
It is just a thermal transfer of energy, madam.
Very good. So what happens during surgery? You have done everything right, but your energy source transmitted and it went into the ureter. Poor ureter was intact, but after some days there was slough because of this thing, and then fistula happened. And this is I have seen this. I won't say very rare. I have seen this many times, and the patient comes and she tells, and it comes in my mind, it is ureter injury. So anybody who has not yet responded, this patient comes in emergency to you, how you will proceed?
I mean, this particular patient, as Dr. Kalyan said, there is a scope of conservative surgery because this patient is already...
Conservative surgery? What conservative?
Conservative waiting, ma'am. Waiting and properly getting evaluated. And sometimes in these patients, you may have to wait for tissue edema and everything to settle down before you can offer.
Oh, so the patient comes with urine constantly dribbling from the vagina, and Kalyan wants to wait. Is anybody differing with Kalyan, including
Madam, can I add?
Madam, Dr. Masrani here.
Yes.
Okay, first the patient, when she comes with the leakage, first thing you do is send her blood investigations, see her BUN, creatinine, see whether she is going into a leukocytosis kind of a picture.
I will tell you what has happened. Normal.
Okay, fine. Then the next thing is again cystourethropy.
Cystourethropy. Where will you do it?
No, it's IVP. Okay, fine, IVP or CT urography.
I'm so happy, and Kalyan, I thought you are a very aggressive surgeon. You are all the time conservative. Today. Anyway.
CT urography that we will do.
Very good. We did CT urography, and it is showing in the right ureter 3 centimeter away from bladder, the urine is leaking. What next?
Yeah, so now
you have this investigation in your hand, you have patient in your hospital, what next?
Okay, the first thing I would do is with the urologist and under CM guidance, first thing immediately I would like to do is put a stent.
Who is this person who is responding?
I'm sorry, this is Dr. Masrani.
Masrani, yeah, it seems you have very good experience. Yes, I agree with you.
Yeah,
So,
first thing I will put is the stent. So as soon as I put the stent, so that the pressure in the system goes away and the further leakage stops.
no. If you put the stent, there are two possibilities, and it has happened. Sometimes it goes, sometimes it does not go. What will you do if it goes? What will you do if your stenting fails?
No, madam, see, it depends.
You agree? Everybody agrees with me. Stenting is not 100% of time successful, especially if your stenosis is very, very bad, or if there is a total transaction ultimately with the.
No, madam. So that's what I'm saying. So first we need to find out the whether in the classification of the ureteric injury, where does our injury fall? Okay.
So we cannot go to the book to learn classification here.
Yeah, so I will tell you. So I will tell you that if there is a complete transaction and whether the distance is more than 2 centimeter or it's a partial transaction in which 50% of the ureter is cut, but there is some continuity which is there. So that's what I'd like to find out.
Oh, these are very good. These are theories. You have a patient who is lying there. I agree you will do retrograde pylography. Now there are two situations. Whether stenting is successful, whether stenting is not possible.
Madam.
So in these situations, please, different people who have not participated yet, what will you do in first situation? What will you do in next situation?
Common here, madam.
Baumann,
Actually, yeah, when you had done the CT hysterogram, you can find the complete transaction of ureter is there or some leak is there. If some leak is there and urine is passing into the bladder, don't be in a hurry. Wait.
What do you do?
Counsel the patient. Do
Then
the conservative line of management. Sometimes what happens, the urinoma will form and afterwards the ureter will heal it by itself.
Anybody who differs with Vaman.
Ma'am, Kalyan here.
Yes,
If
Kalyan.
your stent is going and it is draining, it's always better to wait for
So
some.
Vaman is telling na he will not pass a stent, he will just wait on. We people
No, ma'am,
are confusing our
I
audience today a lot.
I differ from him, ma'am.
Very good. So you
I also
differ from
differ.
Vaman, and Vaman will just be conservative, and now you are not conservative and you are differing. Very good. So what will you do?
Ma'am, if the stent is going, then it is
So
always.
you will always try stenting.
Yes, ma'am.
You
Always
don't
try
agree
stenting.
with Vaman, and I agree with you. You will always try stenting. If you leave it
Yes,
like
ma'am.
that, then okay. Anybody else who differs from these two? Or who is with Vaman and who is with Kalyan?
So first is Madam Nagendra here. First is
Yes,
you have to
Dr.
try and
Nagendra.
first is you have to try and stent the ureter. And
Excellent.
once the stenting is there within 48 hours, I have just discussed some cases with
So
the urologist.
that we did,
within
Nagendra. That we did, and the
Yeah,
situation
so
arose.
Yeah, 48
That
hours.
either it was going or not going.
Yeah, if it goes, the leakage most of the time stops, or sometimes little leakage continues, may continue, but it should stop in about 48 hours.
Excellent.
Okay,
So
that is one part.
If
If
you are
the stent does not go.
if you are able to stent the ureter,
Yeah.
leave the stent for 6
Yes.
weeks.
Yes.
Everybody
This is for
agrees
6
with
weeks.
me?
Yes, ma'am.
Now I would like to ask someone, Dr. Hemant, the stenting failed. Urologist was very good, but he could not stent your ureter. This happens. What will you do?
That
What
means
should be
it is a
done?
complete transaction, ma'am.
Yes.
And these are the patient where my urologist says to wait for 4 weeks till tissue edema. Tissue
so
edema
again a
reduces.
Pandora box.
Ma'am, till tissue edema reduces. But theoretically speaking, ma'am, you have to repair it with, if distance is more than less than 3 centimeter, then they try Boris flap or something.
नहीं अभी तो क्या हुआ, we were not able to pass the stent. So the next step was whether to operate now or whether to wait. You want to wait 4 to 6 weeks. Anybody who disagrees with him?
Madam,
Because
Madam,
I disagree.
Can I add Hemant here?
Sure.
Yes, ma'am.
Yeah, I think we were not able to pass the stent, you said, right?
Yes.
Yeah, okay. So then I think in that cases, some urologists prefer percutaneous nephrostomy also as an emergency.
Very good.
agree,
Very
agree,
good.
agree.
But
Okay,
the
so-
question is, nephrostomy is okay to save kidney. The question is, will
Yeah.
you repair then and there she is 10 weeks post-op, or you will wait 6 weeks? Give
No,
me
no, no,
yes
no,
or no
immediate.
answer, Hemant.
Almost immediate surgery. Almost immediate
Very
surgery.
good. So your friend just now said he will wait 6 weeks.
No, I missed this. The net had gone, madam. I'm sorry.
Or your net goes at a very vital point.
Yes, madam. वो upgrade कर रहे हैं इधर इसलिए.
I am just joking. I really respect you. I know you are a great surgeon, Hemant.
Thank you, madam.
But I agree with you. We don't wait. In olden books, it was that let the tissue reaction stop and all that. Who all agree with Hemant, and who all agree that it should be repaired then and there? Who agree that it should be left 6 weeks?
Repaired then and there, madam. Nagendra.
Anybody
then and there.
give an answer like Nagendra?
Yes.
Let the urologist decide, ma'am. Again,
अरे
I'm-
बाबा, पेशेंट तो हमारा ठीक है ना, भाई हमें पता तो होना चाहिए यूरोलॉजिस्ट पे ही सब नहीं छोड़ने
The
का.
urologist will take this call only, Kalyan.
He'll agree.
Sure.
Nowadays they agree. Urologists.
No,
Agree with it.
they will automatically
They do
take
agree.
this call. Yes.
Yeah.
What you agree with? You will leave her or you will repair?
Common here, madam. Still for few days, 4-5 days, I will wait. I will manage conservatively, then stenting. If not, then operate then and then.
Anybody who disagrees with Vaman?
I would stent immediately.
You are not able to pass the stent. What you are going to
Then,
do?
madam, operate or do a perc, as Dr. Hemant Kanoja said, first thing, do a percutaneous nephrostomy so that kidney starts draining. Wait for a few days, for at least 2, 3, 4 days for that, the tissue edema to settle, because there's so much urine over there which has swollen up the extraperitoneal space. So that little bit of draining take place, and then operate in 2-3 days time. Not
This
operate
is-
immediately.
Yes, this is one school of thought. But many people nowadays, at the same time, they are opening the patient, doing laparoscopy or laparotomy, and they are doing, depending on the distance from the bladder, either they are replanting or doing ureteric anastomosis, or as somebody said, Boris flap if there is traction on the ureter. I think we will
Yeah,
finish with
I
our
differ,
time with the
madam.
urinary injury
Yeah.
only. Let me proceed.
Vama here, madam. I differ little bit here. If your stent is not passing, and if you have done scopy or you open the patient, you pass the stent, and over the stent, if you take a single stitch and brought the ureter at one
Very
place
good.
closure, then the wound will heal with the latter time.
So there are people who believe that let the tissue reaction stop. And I have seen in my practice, I was at institute initially, years back, they used to do that. Lately, people have started suturing. They are not waiting for 4 to 6 weeks. But these are, depending on case to case, depending on how much is your experience, and everybody says that the ball is in urologist court, you will decide. So prophylactic ureter stenting, I'm not going to go into detail because otherwise we will finish, and there were very good practice points I brought. I will leave this case also because we took long. Now,
Madam, if you're going to put a omental graft over there, that will act as a point for volvulus, madam.
Baba, we are not saying anything. We are just taking different opinions.
No, I'm just saying that if you're going to suture omentum over it, then there is a chance that then that will act as a further focus to form volvulus.
So tell the person who said he will suture omentum, because I don't suture
We will
omentum.
just put it there. After burying, we will just put omentum there. We will not suture.
Okay.
I think there's no harm in putting the omentum. It's absolutely fine. It's not going to harm the patient. It's fine, absolutely.
If you take a stitch, it may harm.
Okay, agreed, Makaran sir.
Not
Okay.
taking the stitch.
So Dr. Makrand and Dr. Hemant, what is the consensus, Sujal?
Yes, ma'am.
They both are differing with each other, so you have to now come to the rescue.
No, madam, we are not differing. We
We are not. We are on the. We are on the same.
We are on the
page,
same
madam.
page.
So friendly way you people have come to a compromise, then there is no problem. So we proceed further. This was the injury. If you leave it, it will become like this. And I think I will leave this case also because we will finish with our time. This was lovely cases, and that we have seen. This is a patient. Isha, would you like to present the case?
So 52-year-old para to life 2 with a endometrial hyperplasia, underwent a TLH, and at the end of the procedure, we can see a big vaginal tear.
This happens, especially people who are using manipulator. They will agree with me. In previous scar cases or old patients, there is a tear. So the next question I would like to ask my worthy panelists is, you see how you diagnose or how you will diagnose this tear, because you cannot miss this tear. Patient will bleed in the post-op time. How to make sure there is no tearing?
Madam Nagendra here, one of the things is when you are doing large uteri, you always inspect. Once you remove the uterus from the vagina, you always inspect the vagina completely for any tears. So the tears are, most of the time we see these tears along the lateral walls. So if we see them, then I prefer to suture the tear from below, from vaginally, and then go laparoscopically and repair the vagina.
Thank you, Nagendra. So when you are leaving theatre after a difficult TLH or in a very old lady or where no vaginal delivery, please have a look from below whether she is bleeding or not. Please put the scope in the vagina and see whether there are lateral tears or not. And now I would like my worthy panelists, because Nagendra said he will always like to suture it from below. Anybody differs with him?
Yeah, Vaman, not necessarily we can suture it from laparoscopy.
So how many of you are suturing it laparoscopically? How many vaginal and how many changing depending on situation?
Madam, can I add?
Yes,
yeah, madam, it really depends on where the tear is. If the tear is lower down towards the perineum, why would I suture with the laparoscope? The tear is high up, definitely with the laparoscope, there's no question about it. And the only thing is not to try and cauterize these bleeders, better to take a suture, because everything is fallen apart, the ureters are very close. In fact, any void bleeding also after hysterectomy should be dealt strictly with suturing rather than again and again using thermal energy over there.
Thank you for complete answer. So we proceed further. Now there is one more patient, and yes, Dr. Isha.
42-year-old, para to life 2 with fibroid uterus. She presented on post-op day 6 of TLH in the emergency with complaint of pain, abdomen and bleeding per vaginum. She had tachycardia, pulse was 102, PP was 100/68, pallor was there, abdomen was distended, bleeding was seen through vault, and ultrasound suggested of 500 cc of hemoperitoneum.
So you have done TLH, and after a few days in the night patient comes, she is pale, ghastly pale, abdomen distended. Anybody, how will you proceed with her management? This patient, she comes in your hospital after you have done TLH 6 days after that. What do you do?
Hemodynamically stable, not stable.
She is hemodynamically stable. BP is 100/68.
What is the blood pressure?
Her 100/60.
100/60.
100/60. Okay. And other, fine. So basically, she would require a surgery. The question is that do I operate immediately?
That you have to decide now. Ball is in your court.
Yeah. So basically, she's
whatever you want to ask me about her condition, you ask, and then you manage her.
Okay. What is there a facility for scan available?
Yes, scan is available everywhere.
It's a multi-speciality hospital, right?
Multi-speciality. Even if it is single specialty, scan is available everywhere. Yes.
Okay. Now then we just cross-match the blood, start transfusion. If the hemoglobin is really low, go in.
Really low? What do you mean by really low?
Anywhere, anything less than 7.
Okay. Her hemoglobin is 7, not less, not more.
Okay. Then I would cross-match the blood, start 1 unit of blood for her, keep 2 bottles, further packs as ready.
Very
and
good.
Put in a scope.
There are divine.
So you will straight put in a scope, or you will do something before taking the kid.
No, assuming.
Darwin.
Huh? Yes. You may be right. I'm just asking.
No, I'm assuming that all the other parameter and blood workup is normal.
Yes, normal. She's passing
would...
urine. You should ask me. She's passing urine. Her KFT is normal. In emergency, use chant.
Yeah. So then I will put in a scope.
Okay. Would you like to see whether she's still bleeding or she's not bleeding?
Ma'am, this is Dr.
Madam, see, I'll tell you.
One by one, please.
See, madam, two things. I'll tell you why I said I'll put in a scope and not wait. So such a big hematoma, if she is having half a liter of blood which is there, even if she
100%.
stops bleeding, there is a good chance that it will get infected.
Perfect. That is what we did. I never said that you are doing right or wrong. Why you are doing so.
So there is a very good chance that she will get infected, and then there will be a pelvic abscess that we are dealing with.
Very good. So you
Madam,
will
can I
put
add a point?
What is in your mind when you are putting a scope? What all you may encounter there?
No, so basically what I'll if I can identify the bleeder, which is very, very unlikely that I'll be able to identify that particular bleeder.
So there is no active bleeder, but there is 800 cc blood and clotting there.
Then madam, go in, open drain all the blood, open the extraperitoneal space, identify both the ureters, and then identify the uterine artery at its origin and ligate.
Very good. Who is this person?
Masrani madam.
Masrani, very good. Straight answer. So you will look for uterines at origin. But
Yes.
suppose somebody is not confident in the middle of the night, they don't want to dissect that, and there is a generalized ooze at the wall, and she is not having active bleeding, you have removed all the clots. What is the other alternative? I agree
Call
with you. Ligate.
Call madam someone who's experienced to help
So
you.
you will ligate uterines or you will ligate internally that?
Madam, internal,
What are you doing?
I'm ligating uterine at the origin, madam.
Okay, anybody who differs with him or everybody?
You can just go in, madam. You can just go in, open the pelvic peritoneum and just put a clip on the internal iliac. That's all.
Oh, very good. So he will put a clip on
if
internal
you have to, if it comes to that.
He will dissect and ligate uterine.
Other thing, one thing I would like to add is majority of the patients who come after this sort of delayed post-hysterectomy bleeding is bleeding at the vaginal voltage, and the funny part is they'll come with a gush of blood. By the time they come, the bleeding has stopped.
Very
So all
good.
you need to do is just give tranexamic acid, wait
Very
and
good
observe.
practical experience. This
Do
happens.
antibiotics.
Common here, madam. I'll differ. Yeah.
Very rarely you'll have to go
If
and
the
explore.
hematoma is already formed, organized, patient is hemodynamically stable, when you scooped out the hematoma and there is no bleeding, I don't think doing other interventions like going to the uterine artery or internal iliac, I don't think that is
So
necessary.
all the panelists are giving different answers. So what poor audience will take
Madam,
home message?
Can
Anybody
I add,
who
madam?
can?
Hemant here.
Yes, Hemant.
Yeah, first of all, she requires immediate intervention because she has hemoperitoneum 500 cc. Now, vaginal.
Intervention in terms of laparoscopy is a must.
No, that
If
depends on
there
your
is a
experience
hematoma,
level.
is there any other conservative option? Anybody?
No, with 500 cc in the abdomen, I will definitely go inside and remove
It was
because
200, 250 cc.
probably if she's stable, then I would like to wait and then probably uterine artery embolization or even this radiography.
But anybody would like to take her in the theater, take a nice look at the vault and nicely pack the vault? Anybody who has done this and their patient?
Madam, we have done it with vault bleeding, secondary hemorrhage, but not in cases.
This is
in
secondary
normal...
hemorrhage, the 6 days.
Yeah. So in secondary hemorrhage, most of the time there is no hemoperitoneum. If you see above the vault, there is no collection. So
There
in
is no
those cases, in those cases, conservative management is definitely 100%.
What do you mean
almost
by
100%.
conservative management? Tell
Yeah,
me
as you
about
said,
it.
packing with hydrogen peroxide and all those things definitely
So
helps,
very
and
good.
starting
So
antibiotics.
what are the situations where will you do packing? Please summarize.
First of all, we'll do a scan and see if there's any intra-abdominal or above the vault collection of blood. If that is definitely ruled out, as in most cases of secondary hemorrhage, conservative manage with packing and antibiotics almost 100% helps, even if there's a lot of
Other
bleeding.
panelists agree with him.
Yes, madam.
Then
Yes.
why we were jumping to laparoscopy?
No, madam, she has
Oh, madam, you
500
said there is a
collection.
collection.
Very
When
good.
there is
Because
collection.
there was a big hematoma.
Yeah.
But let me
Level
tell you,
hemoglobin.
there is good evidence that if it is a clean cut case, if there is some amount of hematoma, not very big, you can leave the patient conservatively if she is stable, not bleeding. Because
Madam,
not all hematomas get infected.
Yeah, but some
I
hematomas,
stand to criticism, yes.
some hematomas can even cause consumptive coagulopathy. She can really grow up with DIC if it,
So, very small hematoma, you can still go for conservative, but a bigger hematoma, you have to put a scope. And if you are not very good in laparoscopy, there is no harm in opening the patient. Life is more important then your root hair. All must remember that.
It's perfect.
So, second was, once you have done laparoscopy, somebody said uterine artery, somebody said internal iliac, somebody said generalized ooze, just clear the hematoma. All three options are good depending on severity of situation. If she's not actively bleeding, I don't think that you should poke her in the presence of all that hematoma. You should dissect vessels too much. Somebody said this answer. I agree with that person.
Madam, see, I'm sorry, but I would slightly differ with you in this.
Sure.
Yeah.
That is why we are sitting here.
Yes. So now what happens though, madam? What happens is that these are very slowly growing hematomas, okay? So today you will do a scan, oh, it's a 5 centimeter hematoma, let us wait. Tomorrow you will do a scan, अरे 5, 6, 7 उतना ही दिख रहा है. The hemoglobin आज 9.5 था, कल 9 है. You know, we'll be just dancing around for 10 days, not doing anything. And that time, ultimately, after 10 days, you will have to go inside.
I respect
Madam.
Any very easy way to prevent collection again and again? Can you do some little maneuver so that this rehematoma will be much less? Anybody will answer that?
You mean to say conservative, madam? Conservative approach?
No. You did laparoscopy. There was diffuse ooze and it was not active. You did the hematoma nicely.
Yeah.
I agree, if you are not so senior, you don't want to dissect vessels. There is one more very important practice point, which many times will be very good to prevent recollection.
Vaman madam, after scooping the hematoma, you put some hemostatic agent and obliterate that ring.
What hemostatic agent you are putting? Let the audience know.
Even you can put the hemostatic foams or Abzel.
Which foam you are using? Very good.
Abzel we can use.
Adgel.
We can put it there and we can suture over it.
What are
Even
you
we can
putting,
put a
Sujal?
pass.
Very good.
Yeah.
What are you putting, Sujal? In excess of
Sometimes, very rarely, but Abgel, after I have no experience in doing it in the chronic case. Abgel usually we use during the surgery when liposing is there.
Apart from Adgel, what are the other modalities available? Which, if Adgel is not available in the theatre, what else you can use here?
Madam, you have those solutions also. Some solution which I never used.
Tell the audience so that they are.
I have never used it. I find them just psychological impact.
So you think it is totally useless? Somebody said first the Adgel. Anybody else's experience?
Yeah, Vaman here, madam. Yeah, if Abgel is not available, what you can do is soak the gauze pieces with the paws and the silate, and you put it there and compress it. The minute oozers will stop after a few times, and then you take out the gauze and then obliterate the cavity.
Okay. And any other method anybody would like to do to prevent further bleeding?
Madam, the best way is to devascularize, as Makaran mentioned.
Okay. What else? Anything else? I thought somebody will answer that at the end of the procedure, just put a drain nicely in the place. Why are you laughing? There are people who are youngsters sitting and learning from you experts. You all are big surgeons.
I think, madam, the message should be whenever there is slightest doubt, even in any case, put a drain. That is what I follow.
Thank you. What else?
Madam, one thing
I thought you people you have such heavy practice. You must be using some other hemostatic materials. You will come up fast so that the audience goes.
No, madam, we are good surgeons. That's why we don't use hemostatic agents.
So your juniors must be, creating sometimes. What is the role of Surgicel? What is the role of?
I never use it, madam. I don't know.
So people, in conferences we see. So none of you is convinced that these things are of any use. Is it?
Yes.
Oh, okay. I think we have taken longer time, but I really enjoyed talking to you all, and you all are so good in your